to the course that will be 8 sessions. And what I want to do is start with medications. And only because I think it makes you feel good that you hadn't forgotten a lot. And you really haven't. Now, there are some new drugs, but I have never left the profession, and I still have to look them up. But it's so much easier now. I've got Google. I've got all kinds of things to just look it up, where we used to have to hunt for a PDR to look it up. So life is much easier with our medications. The part that's just never changes is the checking. And we've just got, and that's all us. And that any mistake is us, and it's our doings. So, in your agenda, I want you to turn to the medication page, and I want to say it starts at 16. And I'm sorry about the numbers at the upper right. They're not all clear, and I just can't tell you why, but they're just not. On page 16 of the agenda, what we're not going to go over, we go over medicines several sessions. I don't want to do all medicines today, boring to death, medicines all day. So we don't do it, we do just a little bit. And when I'm getting tired, I'm pretty sure you're tired of medicines, because then they all kind of go together. But if I have a little check, a little hyphen by the drug, they're the ones that I think are being used in this part of the country the most. And so you've got what they're under, the category they're under. On page 16, we start with anti-infective drugs. Feel free, if you need to write something in the side or a little bullet word or whatever. But you may not need to write a thing because you know what it is. And so we try to go pretty swiftly. What I ask is that anybody in this class that has a tidbit to share, maybe you were on it and you knew something about it, share it with us. Also, with me, correct me, because sometimes I think I said something and I said exactly opposite, and you know it's wrong. Don't hesitate to say, did you mean thus and so? Or, that isn't what I heard on NPR this morning, and because I can't keep up with everything. So correct me and do not feel bad about it. Or if I've said something, and I'll say, did I say it that way? Yeah, you said it that way. So help me teach. So the first one marked is acyclovir, and if you break that down, the A, you put a line around A, and cycle down, and vir. And you know, it's anytime A is in front of something, it means take it away. So it's a cycle of the virus. So you know, acyclovir tries to work on our virus by stopping the cycle. We can't kill a virus, but we can stop it. So acyclovir is used, and there's your famous of all, is the Zovirac. Amoxicillin, you know, everybody knows amoxicillin for your antibiotic. Drop on down to ampicillin, same thing. And then go to zithromax or erythromycin. And, you know, so often it's in the set category. You take 8, then you drop it, you taper off with zithromax. But it's a good antibiotic. Some of these next ones that are not marked are used, but not as frequently. Drop down to Keflex, and you know that's the PO of cephalexin. Cipro, we're still on the antibiotics, and then cliamycin, and then doxycycline is, I want to say, is sensitive to potassium. Sensitive, is that right? Sensitive to potassium. It may not be. Forget I said that. Does anybody know something about doxycycline that we want to remember?
Sunlight.
Do what?
You have to say it in sunlight.
Sunlight, light,
Yeah,
light. As soon as I
antibiotics
said
are
it,
light
yes,
sensitive.
light is what I meant to say rather than potassium. Did you say you have something to say, Henry? Was that what you?
I was saying it was one of the first broad spectrum antibiotics.
Oh, really? Uh-huh. Great. All right. Yeah, it's light sensitive. So if it's an antibiotic, doxycycline, that is being hung antibiotic, it's usually put in a little brown bag so that the light won't destroy it. Erythromycin, nothing particular on that. It is pretty hard on the GI tract, but if people can make it, fine. There's diflucan, and see the ZOLE indicates it's a fungal biter. And then go on down to Flagyl, which the ZOLE. See? Aren't you? Why are you in this class? You know these drugs, don't you? It is kind of fun to realize you hadn't lost a lot. Drop on down to penicillin V. We don't need to say much about that. Tetracycline I do want to speak to because there we have another peculiarity, and that is it's binding with calcium. Is that right? That you don't want to, and usually the pharmacist is so good about putting on the label, do not eat anything calcium for 4 hours, or if it's in your stomach. So tetracycline, and then in the old days, and I probably don't even ever tell you all, if it was taken as a liquid or something, it would turn your teeth dark. But we don't have that problem really now. But it is, and why don't you write off to the side, because I just learned this. If somebody is on Synthroid, and we should wait till we come to Synthroid to say it, Synthroid given with, I'm going to tell you, Synthroid does the same thing as tetracycline regarding calcium. So if somebody's on Synthroid, they're supposedly not to eat calcium when they take it. Wait.
No, I take Synthroid, and I can't eat for a whole hour. I have to take it. I can't eat, and if I do take any GI medications that will interfere with it, it has to be like 4
Okay,
hours.
see,
2
it's
or
that.
4 hour diet. I can't remember, but
Okay, so you need to really have it not with any food that might have calcium in it, because it's again, it binds with the calcium and goes out your feces and doesn't get to absorb. All right, and then Bactrim or Septra, and above I've written Cleocin is for MRSA, and you're up here, you know, clindamycin is Cleocin, you saw it up there. Well, it's what's being used a lot of times for MRSA, and Bactrim and Septra. MRSA, methicillin-resistant Staphylococcus aureus. We're going to talk more on that. I want you to realize that, and you see that Bactrim has some, the ZOLE, some fungal properties there. And Bactrim and Septra are anti-infectives. They're not biotic. Antibiotics are anti-bio. Bio is life, and they kill. But anti-infectives make the milieu, the surrounding, not viable for life. So it doesn't kill, it just makes it where it can't live. And those are called anti-infectives. And they're different. Now, ultimately, they're doing the same. I mean, they're getting rid of it, but in a little different way. And so that's why don't embarrass yourself and call Bactrim an antibiotic. It's an anti-infective, just as Septra is. Cleocin is an antibiotic, of course. MRSA, I want to say, I would like to come to that page. I think I have a page on MRSA. But we'll look for it later. Yeah, we'll talk about it later. All right, and then Valtrex, which is, look at that, cycle of the virus in that word. So obviously it's for a virus. Again, doesn't kill it, but tries its best to get rid of that virus. Now, in the little print, Levaquin is quite popular as an antibiotic. And go on over to Vefen, just underline it because those are being used now. Levaquin, Vefen, just antibiotics. But Zvox, I wanted to mention because it is used for, I want to say, I think I'm right, I'm going on memory, but VRE, vancomycin resistant enterococci. MRSA is a bear because you're resistant to an antibiotic. Well, VRE, you're resistant to vancomycin. And that it's not a good thing to be resistant to antibiotics. And so those are very mindful problems. So Vioxx is one of those that can be treated for VRE. And I'm going to talk more about VRE. Not much more, because frankly we don't know a whole lot about these resistant ones. Let's go on down to arthritis and pain relief drugs. There's acetaminophen with codeine. And of course, anything that has codeine, they add the number. If it's 15 milligrams, it's number Tylenol number 1. Or if it has 30, it's Tylenol number 2. Or because it means it's got, and 3 is 30 milligrams of codeine. So if it's Tylenol with a number, it's got the codeine. Allopurinol is lowers uric acid, if you want to write that. And so why is it under arthritis? Because they think that deposits are in the joints. Uric acid makes deposits in the joint. And so allopurinol will cut down some of that, some of those deposits and send them on out in the urine. Uric acid is a waste product. We're going to talk more about it. But uric acid is a waste product of protein. And we're familiar with gout, which is high uric acid. But you know, gout is anybody that has gout, you ask their diet and see what they've been eating. And it's been probably muscle meats. Protein, oh yeah, protein. But protein's got to have a waste when it's broken down. And if I know a man who has terrible gout, it's because he just eats a steak every day. And so he has a high waste product. And so he has gout. But it's those deposits of the waste. And it's too much for the kidney to get rid of. Our kidney does a great job of getting rid of uric acid. But it can't if we give it too much, like any of our organs, if it's given too much. So allopurinol is given to try to help get that waste out of our bloodstream. Go on down to fiorinol, and I think it's just good to see what's in them. You've heard of fiorinol. Well, look, it's got caffeine and aspirin. And I think this is just as good a time to any to talk a minute on aspirin. Poor thing. Aspirin's gotten such a bad rap, and it's a wonderful drug. And they say mummies that they dig up in Egypt they can tell that they had aspirin. So it's been used so long and has lasted all these years. It got a bad rap, and I think it was pharmaceuticals that did it. You can say, now wait a minute, what about the Rye's disease? Is that the disease children will get if they have too much? But I talked to a pediatrician because I reared 3 children on aspirin, and they did not get Rye's. Well, you know, everybody that smokes doesn't get cancer either. And every football player doesn't get a concussion. But this pediatrician told me, I said, I just don't believe that Ray's business. And she said, we have to do it because the literature, if we did it and gave aspirin and the child had raised, we'd sued to death malpractice. But she said there is no reason after 12 years of age that people can't take aspirin. And they can as children, but just it hits some and they get the disease or get the illness. It's just such a great, I heard a lecture on aspirin, and yes, it's hard on the GI tract, but you get real smart and don't take one on an empty stomach. You know, that's not a hard concept. And all the others have anti-coagulative components. Aleve, all those have anticoagulation, and aspirin does too. But aspirin, I think, now this is my thought, I think they got a bad rap because they're so cheap, and the pharmaceuticals wanted more money, so they put out bad literature on it. About the worst thing they do is if too many, you've got some blood issues of bleeding especially black stools or what, the GI disturbances. Well, we can work with that, and you don't do them like popcorn. But you know, you could buy a big old jar for $1 and get 1,000 of them, and they're just so wonderful. One lecture I heard said 2 aspirin is the equivalent for 50 milligrams of Demerol in analgesic aspect. And we now have, and I'll point it out to you at another time when we go over another list, we have IV Tylenol and IV aspirin, ibuprofen, really. But the IV Tylenol is great. The IV ibuprofen is great too. But I asked somebody the other day why we don't use them more. And now, Tylenol, you know, is not anti-inflammatory, and please help the public know that it's the only one. Keep your page there, but go to your brief and turn to medications are on 16, I believe. So go to 16 in that one too, and go to, let's go to, page 15. And middle of the page, you see a list of analgesic, antipyretic, anti-inflammatory. And in the middle of what page? So you see, and it's blurred out Advil, but make it be right. Page 16, I'm sorry. Is it 16? It's 15, isn't it? Huh?
16.
Is it 16? Oh. Oh, okay. Page 16, I'm sorry. So there they all are analgesic. All of them are antipyretic, but there is Tylenol that is not anti-inflammatory. And just help people realize when people say, well, he wants me to alternate Tylenol and ibuprofen or Motrin, and it's because Tylenol is good for pain and it's good for temperature, but it's nothing for inflammation. So if the injury's inflammation, then I don't even do Tylenol. I don't believe in Tylenol, and it's my opinion, but I've read that nobody is 85 years old that took it when they were a baby, and they say it's awfully hard on the liver, Tylenol, and so I don't. Why take it? So I don't take it, and it's not anti-inflammatory, and I think so often we need an anti-inflammatory. So anyway, that's just my take, and you can decide for yourself.
My son broke his femur last October.
Uh-huh.
And after the surgery, the surgeon said, we'll send him home with Tylenol and ibuprofen. I thought, oh boy, here we go.
Uh-huh.
Alternating every 3 hours. That's all he took when we got home. He had one narcotic pain pill.
See, isn't that interesting? What a great testimony, Jenny. And I don't know whether you heard, but her son broke a bone and alternated Tylenol and
Ibuprofen, 400
ibuprofen
milligrams.
and never needed a narcotic. See, so we don't need all that, huh?
They all should do that, then all these people wouldn't be hooked on
Well,
these
especially in that
narcotics.
teen
Yeah,
population.
yeah,
That's why it does
absolutely,
happen.
yeah. Thank you for that.
I think he got
Um,
10 narcotics to come home with 10.
Now, let me see. Yeah, I guess that's what I want to say right this minute.
I was gonna say, when I take the flu shot, I've never had the flu. My doctor, he gets expired, and he told me as a precautionary to take 25 of Benadryl and Tylenol before I take the flu shot. And I never have any soreness, I don't have any problems.
Oh, really?
I've never had any problem. And I always take it the first week of October. And I pre-medicate before I go get the shot.
Yeah. And what do you take before that shot?
25 of Benadryl
Uh-huh.
and 2 Tylenol.
And
I
2
take
Tylenol.
it.
Before a flu
And I
shot?
Take it when I go get the flu shot.
25 of Benadryl.
12 hours after, and that's it.
That's good. That's good.
Mm-hmm.
I may have a little bit more to say on all that. Let's move on to, Fiorinol. We did for Fiorinol. Then go down to Lodine. And I don't think I have anything, and if anybody else has anything to say on Lodine, it is used some, but not a lot, as pain. Duragesic patches, which the Gesic tells you that's for pain. Be sure on patches of any kind to, when you remove them, use an alcohol to wipe the residue and then find a different place. And I have my students wipe a spot and let it dry and get the oils off the skin so it does penetrate better. Lortab, which has Tylenol in it, you can see, in Vicodin. Ibuprofen, and then I think we all know prescription ibuprofen is 800. So if you really need the big guns, you need to take 4 of them, the 200s. And again, they say on a stomach with some food. My experience is it doesn't. It's not as irritating as aspirin, and I don't think you have to take Tylenol, run out and get something to eat right now. It's not that way with these to me. It is aspirin. I might want to do that. These others, I don't think you have to be as prudent. But I've worked with nurses that won't let a child get out the door without giving them something to eat if they've taken one of these ibuprofens, Motrin, Aleve, any of those. Methotrexate, and I think we know people get that for their arthritis. It's really kind of cancer drug. A neoplastic, a cancer type drug, but it's good for arthritis. And then MS cotton, which is morphine, extended release. Now let's go to the next page, page 17, and continue. Oxycodone, we know that for analgesic. And Percocet, just keep in mind, it does have acetaminophen in it. And Feldene is not used a lot, but it is for pain. And then Darvocet N. It's still on the market, isn't it? There was some talk. And look, it's got acetaminophen too. So they all love that pain-killing aspect, the acetaminophen, which is, of course, Tylenol. Underline Celebrac, It's good for joint pain. There's Dilaudid, and that's about it. Trexol's used some. They're not used a lot. Celebrac is used.
They still use Demerol?
Do what?
Demerol,
Mm-hmm.
is that still used?
Uh-huh. Oh, yeah. Mm-hmm. I don't know why it's just not on there, but yeah, it's Demerol is still used. Now go to blood modifying drugs. And Trental is extended release. And of course, Coumadin, warfarin is still around and still popular, but it's got all that baggage related to it, which is do blood work every 6 weeks. That's the culprit about it. But it has an antidote, and some of these others don't. These new ones that are so wonderful that you don't have to get blood work, but they don't have an antidote. Lovenox and Plavix, they're very popular right now. Lovenox and Plavix for anticoagulating. Now the diabetes, we're going to have a whole session on diabetes. We'll talk more about our schedule toward the end of the class. But let's run through them real quick. DDAVP, now that put to the side is antidiuretic hormone. And it's just what it says, antidiuretic. It's going to keep you from urinating. You'll hear me refer, I do camp nursing on Lookout Mountain and have for 36 years or whatever. And children are sometimes given DDAVP for enuresis, so they won't embarrass themselves in their cabin, their sleeping bag. So the families send DDAVP with them. And I'm going to talk more about it because it is an endocrine drug, and I want to talk about the endocrine system. But it used to be you only could take it by sniffing it like Afrin. Now you can take it PO. Sometimes they do both. So that's DDAVP or antidiuretic hormone. And this section isn't just diabetes, it is hormones. Decadron is dexamethasone. And I want you to keep that open and then go back to the briefs. And let's see, we were on page 16, so let's look, I think it's going to be 17 in the briefs. Let me see, no, let's try 18 in the briefs. And 19, you say, what are you looking for? Well, I'll tell you in a minute. Let's go to 20. I'm looking for steroids. So it may be 21. Yep, 21. Do you see steroids over on the left? Now, I gave you some. So page 21, steroids, aka Medrol, Solucortib, Prednisone, Cortisone, Solumedrol, Hydrocortisone, Decadron. There's a few others, but I just listed a few. Now, going down the list are things steroids do. And I know you know the one faded kind of half out is anti-inflammatory. That's its biggie. That's what it gets used for so often. And then the other big one that's used is, we know it as hyperglycemic. If you're on steroids, your blood sugar starts getting high. Those are two properties we know so well about them. The one we don't know as well is coats platelets so the spleen won't kill them. I'm going to talk about that later. Taper them off in administration. Remember that? When you gave steroids, they didn't want you to stop completely. You tapered them. And we still want to do that, and I'm going to talk more about that when we get to the endocrine system. Retards growth of cells. Remember, if you're on steroids, you get the buffalo neck and the chipmunk face, and your limbs are spindly, and your midriff is thick. So it redistributes fat, but it's not good. Your skin's thin. Remember trying to start an IV on somebody that's been on steroids? The skin's just like their veins. They pop because the tissue, the cells are not good. They've retarded growth of cells. Ulcerogenic. They cause ulcers, not just taking PO. They can, if too much steroids, you get ulcers on your body. So it's ulcerogenic, genic meaning starts, ulcers. Hyperglycemia, you know if you're on steroids, your appetite's enhanced. You increase your moods, a lot of times you're happy. Decreases healing, and that's what that retards cell growth has to do. You don't heal well, you know that. Skin flushes. And then this is a good one. It's not all over the literature. Can cause an anal spasm or vaginal spasm if an IV is pushed too rapidly. Double the strength of time to IV push compared to other IV push medications. Normally, we give an IV push a 0.5 milliliter over a minute. So if you're giving it into the IV line, you take for a 0.5 milliliter a whole minute to give it. Well, with a steroid, we're going to take 2 minutes for that 0.5 milliliter, just so it does not cause a rectum. You're not going to read that. What you're going to read in a book is it says it may cause irritability of smooth tissue. Well, that's our rectum and our vagina. And one student one time said, I'll never tell that. One night I got teased so badly by, everybody was sitting around about 2 in the morning, and somebody had to give it, and she said, be sure and give it slow, you know, anal spasm. Well, they all just cracked up because it doesn't say it in the books. I told that student, she said one of the doctors was the worst at laughing at her. I said, don't you want to give him one so bad? Give him a shot so bad. But one day I was visiting a friend of mine on my floor where the students were, and the student was in the room, and I'm talking to my friend, and the student said, I need to run go get her Decadron. And I said, okay, go on, I'm going to stay and visit. And this nurse friend of mine that's in the bed said, does she know how to give Decadron? And I said, I think she does. I said, come back here and tell Helen how you're going to give it and why. And she did a real good job of saying, I'm going to give it double, blah, blah, blah. And Helen's the one who told me that I'd always heard it called, if you're giving it too fast, they'll go, because it's the rectum twitches. Helen told me, when we were talking about it, she said, for me, it's my vagina. She said, it's like a wire brush is in my vagina. So that's the reason I said either one. Just don't give it so fast, push. So, Decadron. Oh, so I finished that. Go back to our page 17 of the agenda. And we got estrase, which is estrogen. And again, that's controversial. The hormone replacement is controversial. What can I say? It's such a personal thing of whether you believe in hormone replacement. All I want to say is realize estrogen doesn't cause cancer, but cancer loves it and loves. If you've got the cancer cell, it's going to gobble them up and just get bigger and bigger. But if you don't have the cells, then how do we know if we do or not? And so do menopausal women, should they do hormone replacement? And I don't know what to tell people. Do I? Yes. But mine's a little different. I did research for a couple of years. I'll just tell you what I found out. It was at this point my GYN wanted me to, when I went through menopause, wanted me to take Premarin. That's the popular one, which is the urine of pregnant horses. And I just wanted to wait, and I could tell she was irritated with me. And I said, "Are you mad at me?" Because I wouldn't do it. I said, "I want to do some research." She said, "I'm not mad at you, but you're educated and you're fighting it." I said, "Let me do research." So I did. For about 2 years, I asked any good-looking older woman, did she take hormone replacement? And my research showed she did. The ones I picked out, a woman at church, just aging so well. And I said, "Elizabeth, do you take hormone?" "Oh, honey, since I've been 40 years old, had a hysterectomy, been on estrogen." Well, then I was talking to a friend of mine, and we were talking about whether you ought to get on hormone replacement. And of course, the literature is pretty hostile at times. So she said, "All I can tell you is that my mother was one of 3, and she was the oldest. And at 40, she had to have a hysterectomy, so they put her on replacement. Her 2 younger sisters have never had surgery. They've still got their reproductive organs, so they've never been on any, and they look twice as old as my mother. And I don't think it's to make you look younger. I think we've stripped a lot from our foods that had that property in it. So what I ended up myself doing is a apothecary down in apothecary down in Columbia, and they're called RX factor or RX compound. And it started out, he would just and I went to my doctor and told her, I said, "I understand there's a pharmacy, an apothecary. I mean, just old-timey powders." And she liked them. She said, "Oh yeah, they're good people. I believe in their stuff." Now she was okay with that. So she said, "I'm going to give you bare minimum." So I get it out of there. Of course, insurance doesn't cover it, but it's $30 for 3 months or something. Anyway, I've done it for years, and they notified me about a year ago that the old man that did it has died or quit. But they said, "We've gone to the drop." Now, how much do you absorb? And I said, "Oh, how does that do?" They said, "No, we think it's good." Well, why? So it really alerts you to think, how much does your skin absorb? I've kind of backed off on lotions and creams because how much is being absorbed? If you're giving me an estrogen drop and you're telling me it's going to be great, then what else is absorbing in my skin? So I don't know what to tell you, other than after that, my doctor, she changed her mind about replacement. She said, after several years, she said, "Now you know you don't have to do this anymore." I said, "No, I kind of like it." We never increased.
But, I had a hysterectomy when I was 35 years old.
Okay.
And I've been taking my hormones, and I had cancer. And I asked the doctor, I said, "Well, what about my hormones?" He said, "You can miss 7 days." He said, "But after that, you need to go back home because of your age, and you will have problems." So I did my chemo, radiation, everything.
Yeah.
And then for 7 days, I would not take my food. Then I went back on it, and I'm still taking it. I don't have any problems. It's when I'm not taking it when I have the problems.
Isn't that interesting, Henrietta? Now, you're the only person I know who has ever had cancer that the doctor, it's all right to be, and you're doing great.
Yeah, I don't have any trouble. It's when I don't.
See? And I do think there's something to the old pioneer and farm women whose foods still, progesterone was in your sweet potatoes. And our foods had some of those properties that I think have been taken out. It sounds old wives' tales, but there's some of those that are good. So that's good to know, Henrietta. And Henrietta's saying she had a hysterectomy at 35 and was off for 7 days off your hormones.
Well, see, I took the hormones, then I got cancer.
Yeah.
And they thought that it was, it was in my uterus, but it wasn't. It was in my blood. And I had sarcoma.
Oh, yeah.
the fastest growing cancer
Uh-huh.
there is. And so I was asking them about it. I said, did the hormones cause it or what? They said, no, it wasn't the
Uh-uh.
hormone.
So you stayed off of them for
7 days.
7 days and then restarted and it's done fine for years. Mm-hmm. Yeah.
And see, when they tell me that I need to stop, and I said, no, I have problems.
When you're off, yeah.
I guess I'm addicted to it.
Well, it's okay. Yeah. And you seem to be doing
Well, your
great.
body
so.
needs it.
Mm-hmm.
Yeah, that's good. Thank you for that, because that's good to know that you can take them after cancer.
But I just think you need to be precautious and follow the rules. You just don't, you know. And he told me, he said, you can miss 7 days, you know, during the time you're sick and you can't keep anything down. But after that, you need to start back with your regimen.
Great. That's good.
And I've had nothing in it.
No trouble. Thank you. Go on back to page 17 on the agenda, and we have Amaryl, which is glimmeride, and well, you know that will lower your blood sugar. Now, what I want to say about that and glipizide, which is glucotrol, they lower your blood sugar, but they do them in different ways. Well, do I need to tell you exactly how they do it? I can't keep them straight, all the different ones and what they do. I do know they lower. Some of them lower it by stimulating the islets of Langerhans in your pancreas. Some of them lower it by decreasing digestion so your sugar doesn't pour out so quick. So all I think you really need to know is it lowers blood sugar, and then go and Google why. Because that, I do think if you were teaching a home health patient, it'd be good to tell them. But for all practical purposes, we're going to lower our blood sugar. Drop on down to Synthroid, and it's kind of blurred, but there's Synthroid or levothyroxine. And remember, we're going to talk more when we get into the endocrine system. But Synthroid is synthetic thyroid. You know, our thyroid gland is this gland that looks like a butterfly up here at our throat. And there it is, and it puts out we'll get to this better, but we'll just, repetition's the mother of learning. So it puts out T3, T4, and calcitonin. And so they found out they can make it in the lab. And so T3, T4 is Synthroid, and so it's synthetic thyroid excretion. We'll talk more. Go on down to glucophage metformin. Now that's one of those like aspirin. Aspirin is to anti-inflammatory as metformin is to diabetes. It's cheap and it's used a lot. It's fine. It lowers it a different way. And I may have those notes sometime when we get on diabetes that I'll share how it does it if you care. Oral contraception, there's a whole list of them. And some do it by stopping ovulation. Others do it by the lining being changed to the point that the egg won't implant. There's a prednisone, which is, of course, a steroid. And then at the bottom, I'm not going to point out the little print place things. We're going to do those when I talk about diabetes. There's your diabetic supplies. And then we'll start with, will y'all remind me 2 weeks from today, we'll start with ear, mouth, throat, and skin next time. Now let me see what time it is. All right, go to your briefs and let's look at medications there. Page 16 is 15. Now that's labs. You're in your briefs. So let's go to 16 starts medication. We'll do a page or two of that in briefs. And start with albuterol. Just keep in mind the steroid properties of nasal aids. This is not a cortisol opening, not a cortical opening airway passage medication. Cortisol, does good for inflammatory, but we don't want to overdo the steroids because of all those reasons I told you. It's long term, starts getting those cheeks and neck and distribution, and skin's thin. If skin's thin, veins are thin. And so we just we want to be very cautious on cortisol or steroids. And amphotericin B is an antifungal for histoplasmosis. And it's also include, these are just two others, Albacet and Albazone are antifungal meds. The thing about amphotericin B, it decreases potassium. So you got to watch somebody's potassium. And then this is important, and I hope pharmacy would alert you, but you mix amphotericin B with D5 only. And they'll do that. They're going to send you, if you had to give amphotericin B, they're going to send it in D5W. But if you piggyback it in, you can't piggyback it with saline running. So that's why I bring it up. Photosensitive, so it's in a brown bag. And they like for us to flush 250 to 500 saline prior to the infusion so it won't burn up the kidneys. They want a gush of fluid to flow through the kidneys before you start this drug that is hard on the kidneys. Now, I think if you're out nursing, you hadn't given amphotericin in several years, and you see it ordered, oh my, there's something I need to remember about it, and I can't remember. If you'll just remember, let me see. Yeah. There's another way to remember it. And it may be crazy to you, but I keep in mind a thing, D. Don't do dextrose and dilantin. But you can, there's a drug that you absolutely need to do D5. D5 we can't do with dilantin, but we can do dextrose with another drug, and that's this one. So that's a crazy way to remember it, but go to dilantin. Let's look at that one. Would it be next page? No, go to the next one. Dilantin, page 18. Remember DDD. Don't mix dextrose with dilantin. It'll clabber like buttermilk. Stop the IV, flush the saline, give the dilantin, flush afterwards. That's just common sense. I got to give it in him. So let me flush. I'll stop the IV, flush with saline, give it, and flush again. I cannot use dextrose. But dextrose is running in my main bag. Well, that can be rectified. So the way I remember is don't do dextrose and dilantin. But dextrose does have its day, and it's got a drug that only it can be used for, and that's amphotericin B. Kind of a silly way to remember it, but it's worked. Ancef is, of course, antibiotic. Kefsol is the liquid, most widely used pre-op prophylactic IV drug. And we've already said antibiotic is anti-life, and then we've already done the antipyretic. Now go on down to Aridia, and it's like calcitonin. So what? I'm going to talk about calcitonin. Well, I'll talk a minute, and then I'm going to repeat. When I told you about the thyroid, it produces T3 and T4 and calcitonin. T3, T4 we know has to do with our metabolism, the thyroid and metabolism. I'm just going to tell you now, but I'll bring it up again. Calcitonin is the thyroid, or the hypothalamus, recognizes if your blood has too much calcium. And so if your blood goes up to the major computer, which is your hypothalamus, we'll talk about that more later, but there is I call it the computer in our brain, that has our richest blood supply. And when it hits there, the pituitary or the hypothalamus says, wow, this blood is loaded with calcium. Well, yeah, she loves milk and ice cream and all that. Well, it's too much. You cannot keep calcium that high in your blood. You're going to start getting stones and obstructions, and this isn't going to work. And the body is just so wonderful because the brain then alerts the thyroid gland, excrete calcitonin and take it away. Calcitonin comes out, gets the calcium, and puts it in our bone and teeth. Is that the greatest thing? It's just wonderful. Takes it and puts it in the bones and teeth. Now, and I always say, if I meet the Creator, I'm going to ask the Creator, why then don't you let the thyroid handle low calcium? But there's another organ for that, and that's what I want to talk to the Creator about. Why in the world can't one organ do it? So your blood goes up to your brain, and the brain says, you don't have enough calcium. And see, we've got to have enough for the biggest muscle of all, because, you know, calcium works with our nerve and muscles. And the biggest muscle of all, calcium channel blockers, we've got to have a good amount of calcium. So the brain alerts the parathyroid, the little four, they're big as raisins, on each side of your thyroid, parathyroid, and says, secrete parathyroid hormone. And the parathyroid hormone goes to the teeth and bones and pulls out. So pregnant women, the PTH pulls from their hair, their fingernails, their teeth. Pregnant women, so often the teeth get cavities and all, because the fetus or whatever is taking too much the calcium's too little. So the two organs, we'll talk more, but I just think it's fascinating, the wonderful body and what it does. So Iridia is our pharmacological calcitonin. So if you were home health and your patient was getting calcium plus calcitonin, well, it's because the physician wants them to take in a lot of calcium by mouth and then take calcitonin to take the extra to the bones so you don't have osteoporosis. Isn't that wonderful? So that's why you might see a patient on Iridia and calcium too, to get that calcium really high and then let Iridia take it to the bones and teeth. Aspirin, and I just think it's important for us to realize that 60 milligrams is a grain. I don't know how committed you are to knowing that, but I think it's good to know that. And so 5 grains is 5 times 60, which is 300. Well, that is our one Tylenol or aspirin or whatever. Well, what happened to the 25? Well, they just say that's margin of error. So we call it, not many physicians still use grain 5, grains 10. Grains 10 would be 650, but some do, and that's why I keep it in there. Remember, baby aspirin's 81. And CV problems, cardiovascular problems, they may give the baby aspirin. But you know, that was controversial about a year and a half ago because I questioned a doctor about it. Well, my doctor, he wanted me, I had ablation because I had atrial fib, and he did ablation, and he did it 5 years ago. And I don't know whether you're familiar, it's just a fascinating thing to me. Atrial fib, you know, your heart just won't do those good beats. They just want to flutter, do it 150 times, and it's not good. And if you're not careful, your blood clabbers because it's not doing good. So 8 years ago, he did ablation. And he froze. He did freezing. And I don't know whether, I just think it's fascinating about it. He goes up, angrily, and goes up and burns with freezing spots of your heart so that it'll heal and make scars. And then the current isn't rampant. It stops at the scars and doesn't go rampant. I just think that's so strange and wonderful that it works. So, off all pills, 5 years did great. And then 2 years, this January, December, I could tell I was back in atrial fib, and it had been about 5 years. But I could tell. The only way I could tell is air hunger. I just need to get my breath. But I run a lot. Not run. I'm not an exerciser, but I stay busy, and I just think, oh, you're just rushing around. But when you do that, and it's 180, and they're not good, you're in atrial fib. So I went back, and he did it again. And so I went. He had to see me 3 months later. And so that's when the big blitz for aspirin, that we don't need 81. So I went in, and his PA met me first before he did, see how I was doing. He said, now we want you to be on aspirin, and he said, and maybe a few months on a cardiac drug. And I said, no, last time he told me he was about to quit. After ablation, you don't need all those drugs, and that he was going to quit doing that. He said, oh, well, if he told you that. He said, well, what about the aspirin? I said, well, I want to talk about that because the media has just come out saying they don't think it's worth it. And he said, I said, what do you think? He said, let me just tell you this. I have a 3-month-old at home, and I hadn't read a paper or heard the news in 3 months. So the doctor came in, who'd done the ablation, and the PA said, now she wants to talk to you about taking an aspirin. Now most people don't mind, why bother? She's making a big deal of an 81 milligram aspirin, but I just don't think it's not necessary. Why should I take it? So I asked him, he got his, and just started looking it up and reading about it, and he said, well, now this says about 50-50. Then he did a few more, and he said, you know what? I think I just do what I want to. Because it's controversial of whether you even need the 81. I'm not saying always, but at least, and I told, and I won't take an anticoagulant because I said I can tell when I'm atrial fib. Why should I take an anticoagulant when I can tell? I get it, and if I was staying in atrial fib, I'll take an anticoagulant. But then you just got to think things out, I think, for yourself. All right, let's move on to Atgram, the passive acquired ready-made antibody. I don't give it, but for some reason I put it in there. But one thing it does stimulate me to say is remember that we all know that, I'm going to talk more about it in immunology, but you get an antigen, or your body thinks you've got an antigen. It may be you don't have a foreign body. When I was in graduate school, my physiology teacher, and that's been 45 years ago, and I saw her in the grocery store the other day. She saw me and I saw her. She did not like for me to call an antigen a foreign body, but she did let me say the body recognizes it as foreign. Now, it may not be. All of a sudden, your body's fighting something and it doesn't need to fight. Well, the body thinks it's foreign. So she let me go with that. But an antigen is a perceived foreign body that your body gets. And when the body gets it, it doesn't want it, and it wants to get rid of it. And our wonderful body then builds up something, and we're going to talk about it later, to fight it, which is the antibody. And so we make antibodies, But if it's dangerous, you just got pricked by a hepatitis needle, it takes 7 to 10 days to make an antibody. And so we don't want you to get hepatitis. And so you go downstairs and they might, if it's serum, give you an antibody already made up. And it might be from a horse. But it's the antibody already made up. They say they last about 4 months. The baby that got ready-made antibodies, the fetus, they'll last about 4 months, those antibodies. But we'll talk more about it when I talk about the immune system. Oregon eardrops, which is an analgesic. It is xylocaine and an oil mixture. It's good for pain, but it's oily and hard for an antibiotic drop to get through. You can use it for ulcers on a Q-tip for an ulcer at the mouth or whatever. Aralgia, that's it. But keep in mind, I knew pediatricians were given the prescription for these eardrops because they're for pain, but they never told the parents that when you put your antibiotic in there, it's not even getting through the oil. And it just worried me to death that was never explained. I'm sure they're great for pain. I just threw them away. I mean, I didn't get the prescription because I knew it was oil. Give them something for their pain. B&O suppository is belladonna and opium, given for bladder spasms. Suppository is given in the rectum, even though it's for the bladder, and people get a little confused if they don't know that. Still been used years and years, and it's wonderful, wonderful. I think doctors forget about it because sometimes when a patient has spasms, I'll suggest, oh yeah, the doctor will say, because a B&O suppository is so great. Bactroban, just keep in mind, over-the-counter now is diluted, and it's an ointment you need a prescription for the full strength. Its only ointment is used for strep. Use it prudently. It's a cream of gold. Use Neosporin for small things, bug bites. Neosporin drives me crazy because, again, I think the drug companies capitalized on it. It's nothing but Vaseline. They put probably a 30-gallon tub, and they put a few drops, and are able to call it an antibacterial salve. If you put Vaseline, it'll keep the bugs out of the sore. I just think it's overrated. And it's not that it's expensive. I just don't think there's... Do I put Vaseline on cuts? No, I don't. Just keep them clean. But I'm saying it's no better because if you look, Vaseline's just... Neosporin is just an oil salve that you put on, and it keeps dirt out. Hello, it just keeps dirt out. Well, if you'll keep it clean and keep a Band-Aid, you're doing the same thing. I just don't prove it. Now, I do love Bactroban. I think, well, it's a prescription, so it's strong. Now, that over-the-counter isn't. If you're getting Bactroban over-the-counter, and don't use up your points for fighting bacteria by using a diluted Bactroban, is my point. If you get a prescription for the high-powered Bactroban, keep it on top of the medicine cabinet and only pull it out when you're pretty sure that that is strep. Is it strep? Yeah, strep. And how do I know it's strep? It won't heal. It's a sore that doesn't get really much bigger, but it just won't heal. As I said, I do that camp nursing, and doesn't take us long to know it's strep, because they'll come in with a little sore. We'll clean it. We'll put Neosporin on it because they're out in dust. So I'm okay with Neosporin. I'm not going to pull out Vaseline. So I'll just put, but knowing that all I'm doing is putting it over to keep dust out when they're out on the ball field. but it's not getting any better. It's not getting really any worse. It just stays there. But all of a sudden, guess what? A little sore popped up over here.
You know, they got a Bactroban tape.
Oh, really?
It's for like when you have rectal, cyst.
Oh, yeah.
Or
A Bactroban tape. Really? A prescription, of course. Oh, yeah. So just use it prudently and cautiously. And yeah, if you want to use Neosporin, but don't call it any big, great thing. Don't think you're fighting bacteria. You've just closed up from getting germs in there. My opinion, but I think it's right. Now, the BAD, that is not universal, but it's Benadryl, Ativan, and Decadron. In a lot of places, it's a combination IV drip, and it has to have physician's orders. It's for nausea and vomiting, and try not to infuse when giving an antibiotic. I mean, they're just saying don't do them in the same tubing. And then baby aspirin, that I guess that's fairly universal. BASA 81. Benadryl, diphenhydramine, given post-op for narcotic itching, but we know it's great antihistamine, and Henry said she does it with Tylenol prior to or whenever. It's a great antihistamine. Brumex is a diuretic, but it's got a couple of things in it. There, the last one on page 16. That is 16 or 15? 16. All right. I think that's enough of medicine. I'm a little tired of medicine now. So let's stop medicines. And let's take a little break. And we're going through the agenda and the briefs. So get the agenda. We'll do that first. And I'm not going to read everything in it. It's too thick. But the front cover page, the agenda, the front cover page gives you the objective and the requirements and so forth, and we're not going to read them because you can read them yourself. The next page, which is page 1, is a table of contents. Probably isn't even necessary because I don't think I look at it or anybody else. Page 3 are frequently used assessment terms. And I just think it's kind of a good little helper. It's just FYI. And then 4 is labs. And 5 and 6, I think. 4, 5, and 6 are lab work. Now, here's the deal. One day, now I told you next week, the next time we're together, we're doing respiratory. And I usually like to tell you before what we're going to do, not that you prepare. But one of the sessions, I will go over lab work. And it's just so that you know what to look for in some of the lab work. We already know a lot of lab work. I want you to keep that open. Go to your briefs, the back page. It may not be. Just a minute. It may be in the agenda. Let me check. Yeah, I'm sorry. Go back to the agenda. Page 36, which is the second from the end, second from the last page. And at the bottom of that page is a box. And that box covers all the lab work that I think you ought to commit to memory. You probably already have it to memory. Page 36, second from the last page in the agenda. second from the last page. Page 36. You don't having trouble? No, now you're in the briefs. That's the briefs. What happened? 16. That's briefs. If you 15, 16. Okay. Now, so the last part of that are lab work. And I think it's interesting. That's page 36. I think it's interesting that all the lab work I gave you in the briefs, 4 pages, that's really the basic lab work that we have committed to memory. And I will give you, I'm not going to today because it's just more stuff to remember. I'm going to give you one of this, which is that, laminated to keep in your pocket, just to pull out while you get them to memory. I'm not going to quiz you. I just think a nurse should know those. And we use them all the time. But I just pointing it out to you. I've got these laminated. I've got some of them, but pretty soon they're going to run out. And so people can just, after you all, just cut that off and keep it until you learn them. Why do you have to learn them? The norm is at a fingertip. You've got the norm on a computer, and you do. But it just saves time on a few of them. When somebody says her platelets are 10,000, I want you to know, wow, they should be 100,000 to 450,000, and they're 10,000? She's going to bleed to death. And I don't want you, I said that quick, you would have had to go through your computer. So a few, and they're not many. I think that's a small number. And that's my 52 years of nursing, that I think that's all you really need to have committed to memory. And so, go back to, so we finished. Now, so one of the sessions, we're going to spend probably an hour on lab work. Now go to the next page. I'm back to agenda. Well, I never left it. That next page is still labs. This page is labs still. We're going, and I'm going to go over all that. Then the next 10, 11, 12. We're still agenda. We're going to stay in agenda till we finish.
She's skipping over quite a few.
Beginning here. The next 4 pages is just data, and I will refer to them off and on. Now, the next one is page 12. The 10 most prescribed drugs in America. And this was 1914, so that's 6 years, really? That's kind of old. I look them up. They're still pretty close. We're still using pretty much these drugs. Now, that's page 12. Now go to 13, and that is the 10 top biggest selling prescription drugs. And again, it's pretty much, I know this is several years old too, but when I do this course twice a year. I kind of look it up, and it's not worth changing. It's so close. Gives you an idea of America. All right, page 14 was the page I was looking for a minute ago, and it is your methicillin-resistant Staphylococcus aureus. And it's an overview, and that's about all anybody knows, that one page. It's such an odd thing. You're resistant to antibiotics. Why? Probably given too many, or you were overdosed. And so this is about all we can tell you. It used to be called the malady that the healthcare givers gave you. And one patient told me one time, said, I've got MRSA, and the doctor told me you all gave it to me. I said, come on, please, thank you. But he's kind of right. That's why we wash our hands and why we do what we do, because we do carry it. But they quit doing. Oh, I'm telling you, Henrietta, you may have remembered too. For a while with MRSA, when it first, we bundled up and put on all this isolation stuff, and I think it was too expensive. They decided maybe we didn't need to. And another thing they were doing was doing cultures in nurses. Well, all of us had it, and carrying it around, but we were healthy, and so they quit doing that too. I know an ICU, at one point ICU were having to let their nurses stay home for 4 months because they had it in their nares. Well, you can imagine the cost of that. So they decided just do universal precautions and we're not going to check anymore. So we're probably all walking around with it in our nares. And that's all right if we just stay real good and healthy. And the healthy things are diet, rest, and exercise, and sleep. So MRSA, and then I don't think I speak to VRE here, do I? I said MRS treatments, Vanc, Zyvox, Zithromax, and ointments are those. But I'm surprised I don't have VRE on there, and I don't. But just put VRE at the bottom so you won't forget. Vancomycin, vancomycin resistant. Enter, E-N-T-E-R, entercocci. It's not on there, Nadra. You have to write it.
Okay.
V-R-E, vancomycin, vanc, V-A, vancomycin, resistant. Entercocci, E-N-T-E-R, cocci. I sure thought I had that on there.
Some of them do.
Yeah, this one does. This one has it at the bottom. But
Does it
others
have?
do not.
But it doesn't have VRE, does it?
Some of them have it written on.
Oh, some people, well,
Yeah.
why don't all of them have it? Well, that's kind of odd, because I read them all at once.
Yeah.
Oh, I don't know. That's odd. All right, VRE, and they say it's worse than MRSA because Vanc's a stronger drug. And they used to, now they're not doing this either. If you took a VRE patient or an MRSA patient, they wouldn't let you take another patient because they didn't want to transfer. Oh, damn, they do. They say use universal precautions, which of course is gloves and mask and goggles and so forth. All right, the next page are the top 10 medications prescribed in skilled nursing facilities. And we're going to have some time on that one too. My next page is 16, and we've already done that one, haven't we? And we're in the middle of, we're at the end, bottom of 17. And you see we've got 18, 19, 20. You see it's going to take us several days, several sessions to work on that. So go to page 17. Is that right? No, not 17. These aren't marked right. 21 is really, but I don't know why that got marked that way. This is the one I want. I don't know what cut.
That's 17.
Everybody with me, it has a 17 on it, but it's wrong. What is it?
Mine's 21 over here. Is
Yeah,
that
yours is 21. I ran all these the same. I think this is odd.
I think it depends on how you turn it.
I bet it is. Oh yeah, it is. It is. It's the way you turn them. 17, if you'll turn it upside down, it's 21. Well, thank you, Tammy. Now, isn't that crazy? All right, we'll talk about that next week because that is your respiratory, the pluravac. So we'll talk about that. Now the next, go to 24, 25, end on 25. And I want you to look at the bottom of the page, and you can't read it. February, it says 1972. Really? 72? Yeah, it's old. It's an old article. But it's still good. It's why I use it. It was written by Orcutt and Morgan. And Orcutt, plastic surgeon, retired, lives in Oregon, skis. But when he lived here in 72, he wrote this article. He was a resident over at VA, and he wrote this for the AJN. Well, the care and feeding of chest tubes. Well, we were using bottles in 72. And so why do I keep it? Because it's just like, the bottles are just like the Pluravac here. Bottle 1, 2, and 3. We'll go over it next week. But the Pluravac is 3 bottles. And so I asked him, it's not that I know him that well, but I saw him in the hall one day and I said, how's your article going? 1970. He said, well, it's interesting. Older nurses love it. Younger nurses hate it and think I've talked down to them, and they resent it. And they say that if it had been my professional magazine, I wouldn't have made it so elementary. Very elementary, very elementary. Hey, I like elementary. You can understand. It's not that I know him that well, because I sure don't. But I do know he has dry humor. And so when you read it, and it is good to read it, when you read it, just imagine a man who's making a funny but keeping a straight face. And that's because he says, and the good air goes in and the bad air goes out. And young nurses were offended. They thought that was, he was talking down to us. He said, I didn't mean to talk down. I was saying I hadn't found a nurse that isn't scared of chest tubes. And it is so simple. Let me tell you how simple it is. And so that's why he made it so simple. To just show, y'all don't need to be so scared. It's just good air out, in, and bad air out. So, anyway, you might read it before next time and just realize the 3 bottles, and we'll go over it on the 29th. The next page is a little more intellectual. Get a positive outcome. And it is more, it's similar, but you see your Pluravac there. And so that goes through 29, 30 to 30. And so we're ready for 31, page 31. And that's when we get to our IVs, where those are central lines. Now, your nurses start peripherals, and even LPNs start them. Not in this hospital, but a lot of places, LPNs start IVs. And the state of Tennessee doesn't care. They say if you teach LPN to do it, that's all we need. We just want them competent. So we'll do peripherals, but the central, are done by qualified nurses who've been signed off and physicians. And it either goes in the subclavian or it can go peripherally inserted and threaded to the central line. And it's not that you need to memorize all these central lines, because I don't even make generic students learn all this. But I think it's good to know when you hear that they've got a PICC line or something like that, or implanted port, that you have a little sense of understanding. And that's what we'll do on our IV day. I've got a board that I'll show you visually these. And they take some care, but it changes about every other year, the care of them. Flush them with 5, flush them with 2. All those things are not necessary. If you worked with one on home health, you would go to your car and look it up and see what you need to do with it, or the doctor leaves instructions. So that's your central lines. The next page, 32, is some just IV tidbits. IV venipuncture, starting an IV, some IV hints, and then the next page is getting blood to the lab. And if they've got a central line, nurses get it. If they've got a central line, nurses need to get the blood from the lab. If they don't have a central line and just a peripheral, the lab comes. And it's been my biggest mystery that they have not put that on nurses to draw blood from the vein. Now we start the IV, but they hadn't made us do it. And I'm glad, because it's just one more thing when we're trying to do all our 100 things. And the lab is meant to do it. But as I said, if they have a central line, it's expected that we draw the blood. And those are just some tidbits we'll talk about on the IV day. Now, the drug calculations, there are some problems on page 29, I guess, or 30 something, I don't know, 30. The dosage calculations, that is all the abbreviations that I think you need, top of whatever that page is. 34. I think that's 34 if you can't see the four. Dosage calculations. Those abbreviations are about all you need on calculation stuff. Then there's some problems. I'm not saying that you need to work them. The answers are the next page. And the next page, 36. And then you've got your labs at the bottom. I put it in here because this course, I've done this course since '87, and in that there's been ebbs and flows of hiring. And at first, you had to go, anywhere you went, you had to pass a drug test or they wouldn't hire you. Now they almost give you the answers because they need you so bad. But I want you to, if you are one that has trouble with math, work it any way you want to. You can play with those and see, but if you think, I think I got it, don't worry about it. It was just put in there for you to practice if you thought you needed to. Then the last page is IV solutions, and we'll go over that again on IV day. What I like to point out is one of the biggest mistakes I find in the early morning is middle of the page, you see D5, 0.45 or D5 1/2, because we know normal saline is 0.9. We know that. So 0.45 is a half. But then look at the second from the bottom one. D5.225 is D5 1/4. But I'll go in the morning, it's happened more than once, that the patient is supposed to be having D5 1/4, and they've got the D5 1/2 hanging because they saw the 4. And that triggered. So I'm just saying, be real careful. Oh, is it fatal? No, it's not fatal. But I like for us to be right. So, and then notice 3% saline. Do you see? If normal is 0.9, do you know how much salt that is? And there's a syndrome that definitely you hang the 3%. That happens to be the syndrome of inappropriate ADH, but we'll talk about it in the endocrine system. So that was that page. Now let's go to I want to go to briefs now. Now, whose do those belong to? Huh? Look for them. They go to the brief. No, that last one is briefs, I think. That last page is briefs, and the other two go in the agenda. Mm-hmm.
I think they were the extras she pulled out of your stuff.
Do you have, see, you don't have that one. Those things go there. She's got those, don't you, Sarah?
Yeah, because I think you
Now,
put mine back together.
here, look and see if you've got these. No. Yeah, you do. You're all right, Tammy?
I'm good. I think they're the ones she pulled out
Huh.
of her stack.
Yeah, they go in Sharon's.
What's your last page?
To the briefs, and the first page 1, table of contents. Now I do use that one. And then we start with assessment terms, and we won't probably go over every one of them, but I'll refer to them occasionally. Now I do mark 1 or 2, just because I want to. Brawny, I just think it's a great term. Edema with no pitting, skin is shiny. And the reason I bring it up is I think edema is an interesting thing to chart. Who in the world can remember 1 plus 2 plus 3 plus 4 plus edema? You can't remember that. So what I say is, if you see somebody, you're assessing them, and their foot I believe that foot's swollen. Yeah, I think it is, yeah. That's a 1. That's qualified for a 1. A 2, yes, it's definitely swollen. Yeah, it's swollen. A 3, hard to say. A 4, it's really swollen. Severely. To the point that it is weeping, probably. Brawny it's shiny and, what did it say?
No pitting.
It's severe, wait, no, it doesn't even pit. It's so tight and shiny. 4 is the one we see where it's pitting and it's leaking. Go on down to generalized edema. If somebody is completely swollen, they are, it's called anasarca. So if you see that word, I see it more than I hear it said, anasarca, generalized. Go to the next page, 4, and let me see if there was anything else I wanted to say on that. I don't think it was. On 4, the urine 24 hours I've marked. This used to be a pet peeve. I think people are getting better. It begins when the patient tells you he's voided and has been discarded. Make sure the height and weight's on the bottle. Check to see if the specimen needs to be on ice. A 24-hour urine, and this is a hard concept for nurses, but as I said, I think it's getting better. I'd get a report, and a nurse would say, and he's on a 24-hour, I put him on a 24-hour urine. And I'd say, so what time? 9 o'clock, or let's say it's report time, 7 in the morning. I put him on it about an hour ago, 6 o'clock. So I say, the jug is empty. No, I started it at 6. Well, that's urine that was made before 6 o'clock. she should have emptied his bladder at 6, and he's got an empty bucket because it started at 6. So before they get to the parking lot, I usually go in and say, before you started this, do you remember the last time you voided? And if it was 4 in the morning, I changed the time to 4 because that was the discarded, and the urine he gave me at 6 has been made since 4. It's a thing that if I were a physician, I'd be so irritated that nurses can't get that straight. But it seems, I will agree, it seems odd to start a test with an empty bucket when you just had them urinate. But it's urine that's been made before now. Now tomorrow morning at 6 o'clock, they'll void, and that's my last one. So you be great at that and don't mess up. The next page is, blood administration. That's page 5, and we're going to do that when we do IV. I'm going to run through that with you. Page 6 is still blood administration, and we're going to talk about. You say, I don't know that I'd ever give blood and fresh frozen plasma and platelets, but it's not that difficult to have that data of how to do it. So we'll go through it. Page 7 is just data. I don't need to give all the data in the world that I've acquired or my friends have acquired, but these are some high points that I think are used a lot. Now, I have a mark by deep breathe cough. And I just can't stress it enough. And you know you can't either, because that is so big in nursing, deep breathing. I don't care too much whether you cough or not, but I want deep breathing. And that is that when you assess somebody, which takes about 5 minutes to go from head to all the systems of the body, that when you get to the lungs, have them breathe deep and listen, and tell them to hold it and then let it out and then push it out. And you can do that when you check their breathing. But before you leave their room, you need to say to them with their friend or family sitting over there, now here's the foot of the bed. Here's what I want you to do today. About every hour, will you remind him to take a deep breath, hold it, let it out, and push it out. And if they cough, they have just announced to you they have not been deep breathing. It's an absolute. When they cough, I'll say, see, you haven't been deep breathing enough. But family will get in on it, and they're just too sedentary. And with that, they don't deep breathe, and they're going to get pneumonia. And I learned that early on. I remember right out of nursing school, I was working, and it was night, and it was a post-op floor, and I gave my charge nurse the vitals, and the temperature was elevated. And she said, have you deep breathed them? And I said, no. She said, go in and deep breathe and take it in about an hour. Whew, that temp was down. That deep breathing is just magic. So, and stress it with family. I don't think people, if it didn't appeal, oh well. So, go on the next page. And page 8, measures. And those are about all you need to know in nursing. A cup of ice is about 120 milliliters. A twin popsicle, 75 milliliters. The single stick's about 52 milliliters. Micrograms, real important to realize. 1,000 micrograms is 1 milligram. 30 milliliters is an ounce, and 60 milligrams we already know is a grain. 325 milligrams is 5 grains, plus 25. A teaspoon is 5 milliliters. And moving along, the next page, 9, I have the routes of administration per tube, per mouth, per rectum. And then self-intermittent catheterization, or SIC, patient doesn't have to use sterile technique. The nurse does have to use sterile technique. And, you know, it's really fascinating to me what's written about our catheters. You know, we've used the Foley, and, you know, it's open. It's open, and germs just climb on up into the tube, into the bladder. And that's why, you know, I'd rather us not have to use Foleys, but they certainly are a convenience. We don't have to go in and spend 30 minutes helping them get up and on a headband and off and on. It's convenient. And the awful Texas catheters, the external catheters around the penis, they slide off or blow up and spill all in the bed. And yet they're better in that they're not intrusive. Now, they say the stats on sick catheters versus Foleys are much better. I'll have to see them. And I need to look that up and see if there really is good research. Because I know people out in the world out walking around, not walking around, they're in wheelchairs. And I've never met a one that does sick that don't keep chronic infections out there. In the hospital, we don't do sicks much. Unless they've been doing them at home and they're in here for something else, they do their own self-catheterization. But that truly is supposed to be self. They're supposed to be doing them themselves. I was and I know her, and she's in by church denomination. She'll come to retreat in her wheelchair, and she was in the bathroom with me, and she just said, I got to do my self-catheterization. I said, well, how do you do with that? She said, oh, fine, I do fine. I said, well, do you have many infections? She said, oh, I keep infection all the time. Well, how can you say that's better? I don't want her to wear a Foley, because that's just open. So I don't know the answer. But the rumbling is that sicks are good. They're better than Foleys. And I get it, because Foleys keep an openness that climbs and goes in. So I don't know what to say about it. I probably need to do more research on it. But that's the last word I heard is sicks are better. But we don't do them in the hospital. You're never going to get them to do them in the hospital because convenience and everything else. All right, the next page is equipment. Page 10 is equipment. And just down to the scales, I wanted to mention scales. I feel for physicians who are trying to keep up with the weight of their patient, because I think weight is important. I know it is. Do we give the same medicine to an 85-year-old woman that we gave to a 250? And I think sometimes we do. And so I hate it that sometimes we don't take weighing patients quite as seriously. Same scales, same time of day, same clothes. Now, our beds now are fabulous in that they'll weigh the patient real easy for us, but I wonder how much was really zeroed. Did they do it with a pillow and a pad and 2 sheets or a big heavy blanket? So I don't even think they're good. I mean, push the button and it weighs them, and it says, did you zero it? Well, I don't know whether when she was admitted they did, and did they do it with 2 pillows or 4? So I feel for physicians who say, well, maybe 4 pillows doesn't make that big a difference. And that's what we have to say. Then the next page, let me talk about this a minute. So the next page is page 11, is it? And I want to mention the TED hose and TEDs. Thromboembolic decompression stockings. The purpose is anti-embolic when patient is bedridden. When ambulating, these are support hose. Should be removed for a minimum of 5 minutes and a maximum of an hour and replaced every 8 hours. Best to replace TED hose after bed, after legs have been elevated and the patient's back to bed. Okay, here's what I want to say about it. And I really am hung up on this for me and you, for nurses. When we walk, our muscles are doing exercises on our veins. And that's why when somebody goes to surgery, it's just flaccid for hours. Then they go to recovery, and fortunately, recovery will probably make them push against them, the palms of their hands, and try to get some motion going against those veins, because blood's getting sluggish, and if it a slightest little rough spot inside our vein, the clot starts building. So walking does this. Surgery, we're flaccid, and the physician says put on TEDs, and it's understood. A lot of times the physician doesn't say, he just said TEDs. But you and I are supposed to know that they need to come off every 8 hours, so they're doing what walking's doing. You say once every 8 hours. Research has shown that you and me, who've had no problems with our legs and flow, one time every 8 hours is all they need to exercise. Now, if we can do more, that's great. So you take off the TEDs, wash that leg, and dry it, put the cream on it or what, and put them back on. Now, that was bedridden. So those TEDs are anti-embolotic if you're bedridden. But like that says, the minute tomorrow morning, when you get out of bed and you put your weight on those legs, you just exercised them. And so I can take off those TEDs and put their feet in water at the bedside and wash them and let them sit there for a couple of hours or whatever. But when they get back to bed, they need to stay at least 5 minutes or so before I put them back on. Because pooling, they sat there and pooled, and that's fine. But when they go back to bed, the pooling needs to rectify and get out of the legs, and we put the hose back on. So they were anti-embolotic as long as I was in bed. I don't even really need them now, but they're still ordered. But once I start weight bearing, I already did what it was supposed to do. But they're still ordered, so I'll put them back on after the flow is out of the legs. Now, if they are let's say they get out of bed and they're ambulating, then we can call them support hose. But they're not anti-embolotic because your walking is the anti-embolotic part. And so my statement is, and I checked with the supply houses. I asked them, because do I need to wash those TEDs today, dry them and use another pair, and tomorrow swap them out? So I talked to the house, those equipment houses, and they said they were invented for obsolescence. They were to be worn out 2 weeks. They said they were made for 2 weeks. You can wash them and towel dry them and do all that you want to, but the elasticity was meant for just 2 weeks. Mm-hmm. Ching, ching, ching. So there's that. So the statement is they're anti-embolotic as long as I'm in bed. Take them off, put them on. Once I start weight bearing, just call them support hose. You don't even need them. In 2 weeks, they're socks. And if you want to tell your patient who goes home with them, did you get my hose? You can do a moment of teaching if you want to and say, now the elasticity's kind of gone, but you can still wear them for socks. Because 2 weeks, they're socks. The supply house said, I don't care if you wash them and towel dry. They were made for 2 weeks. So now I did want my legs to go with varicosities. So I've always worn pretty good hose, Hanes, support. But years ago I went to the supply house and I said, I want the finest hose you've got because I don't want varicosities. And so they look at you and see what you need. And I only wear them when I do clinical. I do supervisory at women's, and I sit down and get up. If you have a nurse job that you sit down and get up, you don't need the fancy hose. But my hose costs $150 and a pair. But How tight are they? They are tight. As soon as my alarm goes off, you get gloves with them. I put the gloves on and put them on before my legs have pooled, so that the tightness, constriction is on the legs that have had 7 hours of hard work, and then keep them on. And my legs have done fine. I've worn them for years. And they last a long time. Now, they like for you to buy them every 6 months. I'm not going to do that. I go a couple of years. Because they're so thick. They're so thick that they don't run very easily. So I don't do every 6 months. But I do believe in compression hose if you're on your feet all that time. As I said, anybody that sits down some and charts and up and down, you don't need them.
So what do you think about those saline?
About what?
Saline.
Oh. To take care of I know. I don't think there's anything wrong with it, but it doesn't last, they say. You know, varicosities, and the doctor will do those little tiny spider veins and shoot saline, and it cleans them out. So if people want to spend their money, that's fine, I think. What do you think? Do you agree, Henry? It's a kind of a waste, isn't it? Yeah. All right, page 12. I don't think this is IV infusion and information, and that's all things we're going to cover when we do our IV day. And page 14, that's going to be IV day. Of course, you know that yellow IV solution is vitamins in it. Let me just point on page 14 at the top, TPN, TNA, total parenteral nutrition. They wanted us to go to TNA and quit using TPN, total parenteral nutrition. You know, it's in the central line. And I bet it's been 20 years ago they said we're changing it to TNA. Well, it's still called TPN. Both of them are interchangeable. And I don't know why they felt they needed to change it anyway. Total nutritional alimentation is that abbreviation. Page 15 starts labs. Well, now, where did that go? Now, wait a minute. That's 15, yeah. Oh, labs were 3 pages in the agenda, but it's just 1 page in here. Then page 16 starts medications, and we've already started that. Everybody with me? Mm-hmm. And we're going to look at the top of 18. DDAVP, anti-diuretic hormone, remember? We'll talk about that. Now go to page 19. They're your insulins, but that's also on your bottom half of that page, and we're going to go over all that. Not that I want you to memorize every insulin, but if you are given insulin, you need to know when it starts, when it peaks, and when it's over. And so it's not that I have you, that's the reason you've got a card, and we'll give you a card to keep with you that you can whip it out and see, because you need to know the peak and you need to know when it's over. So we'll work more on that we have a day that we'll do diabetes. So far I've said we're going to do labs, we're going to do diabetes, we do endocrine. Now go on to the next page, which is 20. I don't think I have anything else there. 21, 22, and 22, there's some emergency medications, and that's pretty much what we're using now for emergency. You know, they've had all kinds that we've used, but we're about down to those. Now, we might use a little lidocaine, but not much. And several that we used to use in the past, but it's kind of down to those. Then nutrition starts. We'll have a little session on that, which is the next page too. And there's respiratory, and that's we're going to cover on the 29th with our equipment and so forth. That page we'll be looking at. 25 is terms. 26 is terms. And, oh, there's VRE, 27. VRE, vancomycin-resistant enterococci, acts like MRSA but more serious. Use Zyvox, and you knew that. Now, I need to speak to wet to dry. If a wound is open enough, it didn't make it sewing it up. It